ฮัลโหลสวัสดีครับอาจารย์ได้ยินไหมครับ
ได้ยินครับอีก2 นาทีเริ่มได้เลย
ได้ครับอาจารย์ขอบคุณครับเดี๋ยวขออนุญาตเริ่มนะครับ Okay. Good morning, fellow residents and professors. Today's topic is on Vogue-Yanagi-Harada disease. It's by first-year resident Poptam and my supervisors, Ajahn Sukhum. So firstly, what is VKH? VKH is a multisystem disorder characterized by ocular inflammation as well as neurological, audiovestibular, and dermatological symptoms. It was first described at the beginning of the 20th century by Alfred Vode, who described bilateral iridocyclitis and eyebrow depigmentation in 1906, and then followed by Yoshizo Kuyanagi in 1926, describing bilateral serous detachments in
Excuse
association with
me,
CSF
Potham, would you please
phagocytosis.
put hello, Potham, do you hear me?
Uh, yeah, I can hear you.
Okay, please slow down your speed for the benefit of the audience. Thank you.
Okay. All right. Sorry. The third person is Inosuke Harada, who identified integumentary symptoms of the condition. The typical ocular features are chronic bilateral non-necrotizing granulomatous panuveitis with exudative retinal detachment. So who's at risk of getting VKH? Firstly, it's mostly pigmented races, so Asians, North Africans, Hispanics, and Native Americans, to the point that top three of the most common identifiable non-fictitious entities in Asia is VKH. And probably due to the fact that they're very low in pigmentation, it's quite rare in Caucasians. Gender-wise, females are more commonly found to have VKH than males, and the average age is approximately on a late 30 to very early 50 range. The disease is also very rare in children. Okay, let's have a look at the pathophysiology of VKH and the mechanisms. The immunologic process fundamentally driving the disease is a T cell mediated autoimmune response against one or more antigenic components of melanocytes. In this case, usually it's tyrosinase like proteins. There's So the driving T cell is usually Th1 or Th17 CD4 cells. These two cells can produce cytokines, IL-17 and IL-27, which induce inflammation in the pigmented areas. The HLA genes behind all this inflammation can be found in HLA-DR4 and HLA-DRB1. DRB4 DR4 is found in Japanese, in Chinese, Hispanics, as well as certain North Americans, while HLA-DRB1 is found in Hispanics and Japanese people. Though it's found that not every single population exhibits the same kind of HLA-DRB1. For example, in Indians, it's found that there is a HLA-DRB1 connection with VKH, but on a much lower scale than in Japanese people. Environmental factors, on the other hand, it's been found that EBV, or Epstein-Barr virus, and cytomegalovirus, EMV, has connections with VKH, as well as cutaneous injury. Next, we're going to talk about clinical manifestations. The disease classically has 4 stages. So that's prodromal, acute uveitis, convalescent, and chronic recurrent ones. So we're going to go into detail on each of these in the next few slides. With prodromal, basically it's flu-like symptoms and meningismus. So you could have headaches, fevers, nuchal rigidity. Sometimes you can even present with seizures. We can also have audiovestibular symptoms, for example, temporary deafness, tinnitus, dysacousia, which is basically pain on hearing. In VKH, you'll find pain on hearing at very high frequencies, and this is found in about 30% of patients. These symptoms of the prodromal phase spans 3 to 5 days before the acute uveitis phase, but could also last several weeks without treatment. A very important thing to note is there is no ocular symptoms or signs in the prodromal stage, of which will be of importance in the diagnosis later on. Cerebrospinal fluid analysis reveals lymphocytic pleocytosis. Mostly because the symptoms don't have any ocular signs. These patients usually initially present into, for example, the ED or into internal medicine with aseptic meningitis or flu. But this doesn't mean there's actually no ocular involvement in the prodromal phase at all. In fact, there's a subclinical choroidal inflammation, which is silently developing in choroidal stroma, and it can only be detected by ICGA. And this is a very important thing to note, because this will affect how we diagnose or how early we can detect VKH. In the acute uveitis phase, basically, what you'll see is a bilateral granulomatous panuveitis with predominantly posterior involvement. The hallmark examination findings you'll see is basically a vitreous cells with bilateral exudative retinal detachment. You also find diffuse choroiditis manifesting as choroidal thickening, which can be seen by enhanced depth imaging optical coherence tomography, or EDI-OCT. You can also see swollen optic discs, as you can see in this picture. And in this picture, you can see the bilateral exudative retinal detachment. The next phase, or the convalescent phase, is basically a phase of depigmentation. So several months, most commonly a year, but it can range from 3 months up to 18 months after the first episode of ocular inflammation has subsided by treatment. There will be signs of depigmentation involving eyes, skin, for example. The sign we most clinically see in ophthalmology is the sunset glow fundus, which represents choroidal depigmentation, showing luminously bright orange-red and small orange-red fundus. You can also find small, discrete atrophic lesions, mainly composed of altered and/or proliferated retinal pigment epithelium cells, mixed with inflammatory cells, for example, lymphocytes or pigment-laden macrophages and epithelioid cells. And these are called Dehlen-Fuchs nodules. You can see here in this picture. Another sign you can also see is Sugira sign, which is basically perilimbal depigmentation, which is depigmentation of the limbus right there. And then the integumentary signs, or the skin signs we see, is vitiligo, as you see with the eyelids of this patient right here, as well as alopecia and poliosis. Poliosis meaning it's whitening of the hair. The next phase is the chronic recurrent phase. So this consists of a panuveitis with acute exacerbations of anterior uveitis. You can see here, there's featuring keratic precipitates. You can find iris nodules, as well as iris depigmentation and atrophy. So with recurrent posterior uveitis, you can also see exudative retinal detachment. It's not an uncommon kind of finding. Most of the vision-threatening complications will develop in this phase, so cataracts, glaucoma, subretinal neovascularization. Now, importantly, we're going to have a look at the imaging modalities. In this case, the first thing we're going to see is OCT. With OCT, we're going to separate this.
Excuse me, would you please go back to the previous slide?
Okay.
For the chronic recurrence rate, in the past we had evidence just for the anterior recurrence of the disease, but however in the past probably past 10 years the evidence has been growing up and show that the recurrence rate can include both anterior either or both anterior or posterior segment, but the evidence showing from the posterior imaging from the even I mean the evidence of ocular inflammation is not as easy as we found from the anterior examination. Okay, so go next to the.
Okay, thank you. So with the imaging modalities in OCT, as you can see here, it will separate this into initial and a chronic phase. In the initial phase, usually we'll see an exudative retinal detachment with septated subretinal fluid, as you can see here in this picture. You can also find RPE folds, but without RPE detachment, and you can also find undulated inner retina or undulated RPE. You can also find a thickened choroid, as you said before. This is in OCT is where we can see this pretty clearly. And in the chronic phase, you'll find progressive subfoveal. I'm sorry, there's a typo right there. Subfoveal choroidal thinning. You'll also find loss of small choroidal vessels with stromal scarring. There can be pigmented scarring with thick RPE and disruption of outer retina, as well as RPE atrophy with thin RPE and disruption of, sorry, that's a typo again as well. You can also find progressive posterior. Hello. So these are two more examples of OCTs. In this one, we see here a serous detachment with a red arrow, septation where the asterisk is. The asterisk is very small right there. Hyperreflective points with a white arrow, retinal pigment epithelial folds, and choroidal thickening and RPE undulations on the green arrow. And here we see more RPE undulations. Basically, it's wavy, curvy RPE. The next imaging modality we're going to talk about is FFA or fundus fluorescein angiograms. This can be
move back to the previous one. You missed one imaging finding that may not, I believe they may not be included in the literature I gave you. So it's about the bacilli detachment, bacilli detachment. I think it will be familiar to the second and third year resident. Is kind of OCT finding in that may involve in many ocular disease entities. The VKS is the major cause of the basal layer detachment. You can go find further information after this hour. Okay, move back. Move next.
Okay, thank you. With FFA or fundus fluorescein angiograms, can have an early to mid phase. And in this phase, it's classically revealed to have a multifocal area of pinpoint leakage in both eyes. And you'll see this as a multifocal punctate hyperfluorescent pinpoint leakage. And this is at the RPE level. Can have focal areas of delay in choroidal perfusion. You can see large placoid areas of hyperfluorescence, pooling within the subretinal fluid and optic nerve staining. I'll have a quick look into the next slide for now. As you can see here, there's multifocal punctate hyperfluorescent pinpoint leakages, all these little white dots here, right here. And The placoid we can see in this picture are the larger round whitish placoids. In the late phase, you'll see an early patchy choroidal filling and areas of delayed choroidal perfusion with early pinpoint hyperfluorescence, disc hyperfluorescence and leakage. Usually the disc usually appears as a hypofluorescence. So with hyperfluorescence, we can see there's something wrong with it. Late pooling of fluorescein and choroidal striae. So here's the pictures for both of them. Once again, the multifocal points of pinpoint leakage in both eyes. And in the late phase, you see a more intense leakage, resulting in the placoid areas of hypofluorescence. And you also see the pooling of dye within the subretinal fluid. Next, we're going to talk about ICGA. And this is a very important modality to note, which we'll talk later on in a few slides later. The four main ICGA signs of acute initial onset BKH are A, hypofluorescent dark dots during the intermediate phase. You can see in this picture, there's plenty of dark dots, hypofluorescent dark dots in A here. These are all hypofluorescent dark dots. And you can also find early choroidal stromal vessel hyperfluorescence and leakage. As you can see here, the vessels are very prominent here. In C, you can see an optic disc hypofluorescence. Once again, the eye optic disc is usually hypofluorescent. So in this case, you can see that there is, for example, optic disc edema. It turns out as hypofluorescence. In D1, you can see here, fuzzy or lost vascular pattern or of large stromal vessels. And to compare, basically D2 is after treatment. You can see more of the choroidal structures after treatment. So in D1, it's really, really fuzzy and you have lost all the vascular patterns. You can also find hypofluorescent patches corresponding to areas of exudative retinal detachment, as well as delayed choroidal perfusion. So here's another example. In this patient, you can see the patient's got retinal detachment, and in the FFA, we can see pinpoint leakages, as well as the retinal detachment right there. So in ICGA or ICG, basically we see the hypofluorescent dark dots, plenty of them right there, as well as a hypofluorescent patch, which corresponds to the exudative retinal detachment. The next modality is the V-scan ultrasound. This is actually quite useful in measuring the choroid thickness because most other modalities can't actually reach the level of the choroid. What you'll find is basically a diffuse, low to medium reflective choroidal thickening. You can find serous retinal detachment, mild vitreous opacities, and thickened posterior sclera or episclera. You can also differentiate this from posterior scleritis, for example. And so in this picture here, you can see serous retinal detachment. There's a mild vitreous opacity and a very low to reflective choroidal thickening right there. And you can see here in the A scan that there's a small little height of the spike showing retinal detachment. And this is basically a summary of all the modalities that can be used to look at VKH. Next, we're going to go into the diagnostic criteria. So firstly, there's no diagnostic test for VKH. The diagnosis is clinically based with exclusion of other possible causes. So there's been numerous diagnostic criteria having been developed to aid in diagnosis. So since 1978, we have the American Uveitis Society criteria, and the latest one we have, which we'll be talking about today, is the Simplified Diagnostic Criteria in 2022. The one we use most of the time is actually this one, which is the Revised Diagnostic Criteria in 2001. And lately, there's also the Chinese Diagnostic Criteria, which we'll also talk about in this presentation. So firstly, the Revised Diagnostic Criteria from 2001.
Move back to the previous one. Okay. Please. I was caused by line, so let me say about the ICG. Yeah, go back to the ICG.
Okay.
Okay. As as it was presented in the ICG finding, hypofluorescent dark dot is not specific to the VKS gap, and also the choroidal stromal vessel hypofluorescence is not specific to the VKS. You can find hypofluorescent dark dot in many choroidal disease. So, but however, it's good to it's good for the monitoring of the disease after the treatment, as Kit will talk later. Next to the criteria, there are two. Kit, move next to the criteria slide. Okay, there are two criteria to be noted. One is the diagnostic criteria, and the second one is the classification criteria that is lately presented by the Sun standard with this nomenclature group that is the world-renowned study group of the UADIS. However, this is the classification criteria that is usually used in the study in the research area. But for us as a clinician, we should pay respect. We should pay attention to the diagnostic criteria that has been used. The one that has been used since 2001, which is I think this is should be the landmark one for you to hold it. Is the diagnostic criteria 2001. However, there are some diagnostic criteria that modify the 2001 criteria to make it more concise and understandable and compatible with the four stages of disease, as Kit previously said. It is about the criteria in 2018 and 2020, but I want you to keep it in mind just for your better understanding for the four stages of the disease. Both of them would include the imaging finding, for example, OCT and ICGA, which has been missed from the 2001 criteria, and some of them may divide the detail of the criteria to be acute, the criteria for the acute stage of disease and the chronic stage of the disease. Okay, move next. Kit, you continue.
Okay, thank you. So as Ajahn Sukum said, this is the landmark diagnostic criteria from 2001 called the revised diagnostic criteria. We'll break this down very carefully. So in 2001, they separated VKH into three categories of diagnosis. So complete, incomplete, and probable. This is according to how many criteria it hits. So to have a complete diagnosis, you need every single criteria from 1 to 5. In incomplete, you need 1 to 3 with 4 or 5, and probable is just 1 to 3. Some comments on this trial. So basically, it's very useful to the granularity of the clinical trials it used to make this. But it's actually quite complicated for clinical use, and it doesn't really incorporate the latest imaging modalities, as we'll talk later on, for example, ICGA or EDI-OCT. And it doesn't really separate between acute and chronic presentations. So once again, with complete Vogt-Koyanagi-Harada disease, firstly, you have to differentiate between, for example, sympathetic ophthalmia. So the disease, the patient does not have a history of penetrating ocular trauma or surgery preceding the initial onset of uveitis. There's going to be no clinical or laboratory evidence suggestive of other ocular disease entities. And thirdly, there's going to be bilateral ocular involvement, which they'll separate into A, early manifestations, and B, late manifestations. So it can have either. So with early manifestations, these are the things we talked about already. For example, focal areas of subretinal fluid, cerebroretinal detachments. You can also find, for example, here, multifocal areas of pinpoint leakage and large placoid areas of hyperfluorescence in FFA, as well as diffuse choroidal thickening by ultrasonography. In the late manifestations of disease, You'll find history of suggestive of prior presence findings from 3A and either both 2 and 3 below these two, or multiple signs from 3. Once again, like what we said before, it can be ocular depigmentation. So you can have the sunset glow fundus. An important point to note of sunset glow fundus is point you have sunset glow fundus means your prognosis or visual prognosis isn't a very good one. I can also have Segura sign, which is the perilimbal depigmentation. And other ocular signs you find is nummular chorioretinal depigmented scars, RPE clumping, or you can also have recurrent or chronic anterior uveitis found in the recurrent chronic phase. Number 4 and 5 are the extraocular manifestations. So with 4, you have neurological or auditory findings, as we said before, meningismus, tinnitus, and if a CSF was taken, you find CSF fluid pleocytosis, usually with lymphocytes. And 5, integumentary findings or skin findings, you'll find alopecia, poliosis, and vitiligo. And to have a complete diagnosis, all 5 must be met. With incomplete Vogt-Koyanagi-Harada disease, the 3 and either only 5 or 4 must be present, and the description is basically the same. And with probable, 1 to 3. Okay, so this is one of the newer diagnostic criteria. This is one is from China.
Kid, move back, please. Move to the next. Regarding the classic one in the classic diagnostic criteria in 2001. There are some points to be stressed. There are 5 points, right? There are 5. Yeah, there are 5 items to be complete, fulfill the complete VKS, but we usually don't find all of them. That you can see for the probable one, the probable VKS, it must include the number 1, number 2, and number 3, right? So I mean the most critical point, the most critical information to diagnose VKS is the patient must have no history of penetrating ocular trauma and laboratory evidence suggestive for other ocular disease must be excluded, and also it must be bilateral involvement. And another point is about the detail of the classic criteria. There are some clinical items that include in the classic criteria that should be, I think it can be ignored for the present day. That is CSF fluid pleocytosis. Like this is going to say later about the latest criteria. The CSF pleocytosis it was mentioned in the previous literature a long time ago, but today we don't do the lumbar puncture for the diagnosis of VKH, and also the Segura sign is the sign that so-called perilimbal vitiligo that we don't usually note it in every person. I don't think is the important sign, but you should know for the reason, you should know for the examination, yeah, and then the clinical sign of the disease. Okay, move next.
All right, thank you. So we're going to go on to the Chinese diagnostic criteria from 2018. It's basically a case control study which reviewed medical records of 634 patients with VKH. So it's very similar to the 2001 criteria, but it added the use of EDI OCT, extended depth imaging OCT. You can see here in D, choroidal thickening on EDI OCT. The rest is generally very similar. With the variants is a few different variants of how you can diagnose it, but basically they added in EDI OCT, and after that they added in the OCT, they found that there was a looking at the receiver operating curve, no loss in sensitivity. You can see here there's no loss in sensitivity, but there's a greater specificity in the newer diagnostic criteria or the Chinese criteria here. So what we can say here basically is OCT helps rule out probably other diseases, but without sacrificing any of the sensitivity the old diagnostic criteria already has. So the latest diagnostic criteria we're going to talk about is the precise simplified diagnostic criteria, which was published in 2022. So with this criteria, they identified the following updates for the VH disease. Firstly, they had a crucial differentiation between the acute and initial onset, between the acute forms and the chronic forms of the disease. They integrated new precise imaging methods, in this case, ICGA, as well as EDI OCT. And then they really simplified the diagnostic criteria. But this is a point to note is this is only for acute initial onset, and they haven't actually done this for chronic VKH yet. And lastly, they looked at treatment optimization through like early vigorous sustained corticosteroid and non-steroidal immunosuppression as the first line for treatment for initial VKH disease. So a very quick look of how important ICGA is. In these pictures right here, you'll see the prodromal phase of VKH disease. So in these two fundus photos, you can see on the right, generally it's a normal fundus photo. On the left, it's more hazy. In this case, they describe it as there's a massive choroidal infiltration on the left. The left image shows that, and this patient was actually diagnosed with unilateral VKH. But this is from the fundus photos, and from the FA photos, you can see no lesions. But with ICGA, you can actually see there's pinpoint hypofluorescent dark dots, or HDDs, in both of the eyes. So what you can see here is, even though sometimes they may present as a unilateral VKH, but the disease itself is always a bilateral disease. So only ICGA can show this to us. Also, as I said before, in the prodromal stage, there's no ocular signs or symptoms. So with no ocular signs or symptoms, most of the time, they won't actually even present to ophthalmology. The only sign or the only way of seeing any ocular manifestations is using ICGA to look at the HDDs right there. So in this case, this is why they propose a new diagnostic criteria, and they put in ICGA, as you can see here. So firstly, it's the same, no ocular trauma or surgery preceding disease onset. Any of these points marked with an A is an essential required criteria. So without either one of 1, 2, 3, 4, 5, or 6, you cannot diagnose the patient with VKH with this diagnostic criteria. Okay. Secondly, you have bilateral involvement, and this can be verified by ICGA or EDI-OCT. Third, there's exclusion of other infectious, inflammatory, or masquerading entities, particularly other stromal choroiditis entities, for example, tuberculosis, sarcoidosis, or syphilis. 4, you'll have diffuse choroiditis, which you'll see thickened choroids, evidenced by, once again, ICGA and or EDI-OCT. And the symptoms must have lasted for at least 4 weeks. And there should be an absence of clinical finding compatible with other chronic diseases. For example, in this case, because this is for acute initial onset VKH, didn't find sunset glow fundus or integumentary signs like vitiligo, alopecia, or poliosis. Okay. Number 7, you can find exudative retinal detachment, once again evidenced by pooling and pinpoint leaks on FA and ICGA. And if you see this, it's a very helpful point. 8, you can see disc hyperfluorescence. Once again, a normal disc is hypofluorescent. And 9, you can find neurological and auditory findings, as you can see in the prodromal stage of the disease. So meningismus, tinnitus, acute hearing loss. Once again, also a helpful criterion. So with this criteria, they compressed all the diagnostic criteria from the 2001, 2018 criteria and made it just into 9 points with 6 essential points that are required to diagnose VKH. And at the core of it, the additional core is basically ICGA, which can detect VKH earlier and more accurately. So here's more photos of
Kid, move back to the previous slide. Yeah, as Kit said, it's important to note that this table is for the acute stage of VKH or initial onset, not for chronic one. You may see that this criterion is a bit different from the previous two criterion. Is it emphasizes on ICGA imaging with why is it straight in such imaging, because you see the first order of this paper is made by the Carl Urbach, which is expertise in ICG. He's an expert in choroiditis related disease. So he usually order ICGA for I would say every cases of VKS. In my opinion, is a good imaging because ICG will highlight the abnormality in choroid, but in clinical judgment, in clinical diagnosis for the VKS, I think FA is still the good one and even more important than ICG for the diagnosis. For me, in VKS suspected patient, I would order FI, but if ICG is not available, I think FA is still okay for it and enough for a diagnosis, including OCT. Yeah, OCT is also needed for a diagnosis of the VKS. Okay, move next.
Thank you. So once again, these are showing the 4 main ICGA picture on the right here. A review again of the 4 main ICGA signs you can see in acute initial onset VKH. Point to note is because inflammation initiates only in the choroid, this structure should be targeted with therapy. So in the choroidal compartment, unlike the retina, it's very easily accessible to systemic therapy. So increasing evidence here has shown that when treatment is conducted with zero tolerance to choroiditis recurrence, which we can detect with ICGA or EDI-OCT, a substantial proportion of patients can be healed before depigmentation occurs. And so you won't even find the sunset glow fundus. You've already treated the patient. Here's more pictures of ICGA showing that it can really detect pre and post treatment fundus. So we could go into more detail of the treatment for VKH and how it correlates back to the diagnostic criteria we just talked about just now. So there's 4 main branches of treatment for VKH. The main ones being corticosteroids and non-steroidal immunomodulatory therapy, or IMT. So the principles of VKH is to treat or suppress the acute causative intraocular inflammation with initiation of early, very high dose systemic corticosteroids. In this case, for example, IV methylprednisolone, usually given at 1 grams for 3 days. And you'll taper this down for 6 to, for example, 12 months with oral prednisolone of 1 to 2 milligrams per kilogram per day. can also actually find topical prednisolone. So, for example, 1% prednisolone forte and cycloplegic agents. Those can be indicated for anterior chronic inflammation, anterior chamber inflammation, either in the initial or chronic recurrent phase to reduce inflammation and pain and to prevent synechia. But topical steroids should be tapered as inflammation subsides, though sometimes you find that chronic or refractory VKH cases can have beneficial benefits by using prolonged low-dose corticosteroid drops. Secondly, we have the non-steroidal or IMT, non-steroidal immunomodulatory therapy. Most commonly, what we find is these four: so cyclosporin, MMF, azathioprine, and methotrexate. These are generally used in recurrent cases, or more research shows that initiating this at the same time as corticosteroids may actually have very better prognosis than starting it later. The third treatment we can use is anti-VEGF. And these are generally for when you have complications. So, for example, with cystoid macular edema, in choroidal neovascularization in CNV, as well as retinal neovascularization. And lastly, we also have biological response modifiers. We'll show this in a later slide as well, but this is reserved for patients not really responding to steroids and IMT. We're going to go back to one of the ICGA photos. So, for example, this infliximab, this patient was given corticosteroids and IMT, but they didn't really respond. So they were then given infliximab as the last line of choice. These are the examples of the IMTs we can use. And as we said before, the ones we use mostly here are usually the cyclosporin, azathioprine, mycophenolate mofetil, and methotrexate. You can look up the doses right here. And the biological response modifiers for VKH, as we saw just now, there was infliximab, it's a anti-TNF alpha monoclonal antibody. And you can also find rituximab, which is a monoclonal anti-CD20 antibody. And that is it. Thank you for listening.
Okay, move back to the treatment slide. Okay, it's very important to note that the initial administration of corticosteroid is the mainstay of treatment, and also the VKS treatment is a bit special from the other UADs entity, since you need to administer the systemic corticosteroid and tapering it for the period of not less than 6 months. That means it should be 8 months or 10 months for the tapering corticosteroid, because if you stop prematurely, the disease can be recurrent. And also the IMT that nowadays I prefer is the methotrexate, because its cost effectiveness is good. And for the anti-VEGF, I would keep it specifically for the neovascular related complication, and not for the cystoid macular edema that can be easily managed with the corticosteroid, either periocular injection or systemic treatment. โอเคตอนนี้ในห้องมีคำถามอะไรไหมมีไหมก็วันนี้ก็เพลิดเพลินดีนะเรามีสปีกเกอร์ Sound Like Native มาพูดเลยนะเนี่ยนะถือว่าก็จะได้ทำให้หูพวกเรากระดิกกันมากขึ้นนะทีนี้มีน้องคนไหนอยากถามเป็นภาษาอังกฤษก็ถามสปีกเกอร์เราได้เลยฮัลโหลมีไหมนะคืออันนี้ก็ใครคือพี่ให้พูดเป็นภาษาอังกฤษเพราะว่าอันนี้ไม่เป็นท็อปิกที่แต่ละคนเนี่ยไปรีวิวเองกันได้นะแล้วก็ แล้วก็เพราะว่าถ้าเป็น journal เรื่องอะไรใหม่ๆที่เราไม่คุ้นกันเนี่ยถ้าบางทีถ้าพูดภาษาอังกฤษมันจะ catch up ไม่ทันนะอันนี้ก็แต่ที่ถ้ามีใครฟังระหว่างชั่วโมงไม่ทันก็ถามมาเป็นภาษาไทยก็ได้นะตอนนี้มีไหม อ่าถ้าไม่มีก็ขอขอบคุณน้องคิดนะโอเคดีนำเสนอได้ดีมากแล้วก็มีเวลาคืนเดียวแก้สไลด์มาก็ทำได้ดีไอ้ยนี้อยู่ใช้โปรแกรมอะไรทำนะ
ใช้
ใช้เป็นอะไรนะโน้ตคีย์โน้ตอะไรปะ
เป็น
หรือ
power
iPad ใช่ไหม
PowerPoint ครับอาจารย์บนคอมครับ
PowerPoint เหรออ๋ออยู่ใช้สาวก Windows เหรออยู่
ครับ
อยู่
ครับ
อยู่ใช้
เป็น
Windows เหรอ
ใช่ครับเป็น
ไอส
ได้
ไลด์นั่นดีนะไอตรงที่อยู่ทำเป็น four stages เนี่ยลองกลับไปสไลด์นั่นดิ
อันไหนนะครับอาจารย์
ไอ้4 อันที่อยู่ทำไปพี่ว่าอันนี้เป็นแพทเทิร์นดีเนี่ยไอเนี่ยไอ้นี่แบบนี้ดีก็คือแต่คือติดตรงที่ตัวมันก็จะเล็กลงนะบรรทัดตัวมัน
อ๋อ
จะเล็กเกินไปบรรทัดมันก็จะเยอะเกินไปใช่ไหมแต่โอเคเข้าใจว่าอยู่ก็พยายามทำให้มันดูแล้วมันต่อเนื่องกันนะ
ครับ
อืมอันนี้ใช้ฟังก์ชันอะไรใน PowerPoint อ่ะ
จริงๆเป็น
หรือว่าอยู่อืม
เทมเพลตจากเว็บชื่อ Slideco ครับอาจารย์แล้วก็ดาวน์โหล
อ๋อ
ดเทมเพลตมาครับ
อยู่ดาวน์โหลดเทมเพลตมาใช่ไหมในเปิด PowerPoint แล้วก็ดาวน์โหลดเทมเพลตมา
ครับ
สไลด์โกเหรอ
Slideco ครับอาจารย์
SLIDEGO ติดกันเงี้ย
ใช่
.com เงี้ย
ครับใช่ครับ
เหรอโอเคดีครับโอเคงั้นก็ปิดได้ครับขอบคุณครับ
ขอบคุณมากครับอาจารย์ครับขอบคุณครับ